Okay, good morning everyone. Well, it's my pleasure to give you a short overview of some studies that we do at Maastricht University in the Netherlands. I hope that you can hear me very well, and also the person that is recording there. Okay, so let's start. I think I have a pretty easy job to do because I'm the first one. I hope so. You all had coffee or very strong English tea. So you're all awake and ready to listen to me. Okay, so if I look at the studies that we cover at Maastricht University, including, of course, a human study in XL-BREF, we focus on really broad spectra of diseases. So we look at the lung diseases, liver diseases, and GI tract. But we also work with different animal models, including sheep and mice. And today what I will show you is, I will show you some results on the lungs and GI tract diseases, and also a recent study that we performed in sheep. So unfortunately, the results that I will be showing you were not done with Resiva. We have been using it for about 1 year. So the sampling procedure that is shown here is different. So we use a Tetlar bag. Well, you all, I guess, know it. You feel it. So we use between 1 liter to 3 liter. Then it's moved to the thermal desorption tube. It's a carbon tube that we use here. And then we use gas chromatography coupled to mass spectrometry to get, of course, chromatograms. Obviously, when we look at XL-BREF data, they are pretty complex, right? We record a lot of data. Next to it, we can have a lot of metadata, so we measure a lot of individuals. And then we have our compounds in XL-BREF next to metadata. So, of course, we have to use a certain procedure. We can use it, we can call it machine learning, biostatistic, data mining. I think the names are coming over and over, but at the end it all means the same. Okay, gather your data, analyze it, and get meaningful information. So it's kind of like a stepwise approach that you collect the data, you integrate them, you transform, you analyze, and of course you visualize to show your results. But when it comes to data analysis, I think we, at least in Maastricht, we try to follow certain strategy. So when we measure our individuals, patients, any cohorts, of course we then try to use certain techniques. But before we do that, we always split our data. So what I mean by splitting is I take my cohort and I say, okay, this part of cohort will be belonging. So we call it training set. And the rest is basically a validation set. And why do we do that? Well, basically we use the training set to find out which compounds in XL-BREF are relevant. And then, okay, we train our technique, we check, we optimize, and only when we are sure that the selected compounds are interesting, we go to this validation set that we like put aside. I always said you put it in the drawer, you forget about this part of your cohort, and you check if your compounds are basically real, or did you basically just make a perfect fit to the data. And this validation is really important because if you don't do it, then you can be sure that your results are not reproducible. You cannot really use it in the future. And in the ideal situation, what we try to do, we go some months later or maybe 1 year later, we collect a new set of individuals and we try to validate it in so-called independent validation set. Of course, sometimes it's not possible, but where it is, we try to do it. So we always follow such a procedure. So then we have our data, we have our training set, and then, of course, if you look at the data I said, it's pretty complex, a big volume of data. So you have there a lot of compounds. Of course, most of those compounds are not interesting. Basically, they are irrelevant. They don't give you any information about the question of interest. So what we try to do, we basically focus on the compound selection. So we try to focus on those compounds that are discriminatory between your classes, so for instance, healthy or disease, or even go further, like a real biomarker. And for that, of course, we can use different techniques. There is like really such a broad spectrum of techniques that can be used. But again, a remark, okay, use it, but be cautious because you can find those compounds, but if you don't validate it, they will be only valid for the cohort that you are looking at. Okay, so let's go to some examples. So I told you that I will show you some results on the lung malfunction, and we did a study in asthma in children. So, well, asthma is pretty interesting disease to study, right, with exhale breath because we have their inflammation. It's the most common illness in childhood, and the problem with asthma is that the real diagnosis can be done at age 6. So it's pretty late because a lot of children are overtreated or undertreated. And the aim here was to see if we can use exhale breath to distinguish so-called wheezing from asthma. So at preschool children. So preschool children is about 2 years, 4 years old children. So what did we have here? So we had 252 children. We collected their breath from age 2 to age 6. So you, in general, each child delivered between 3 to 7 samples. So in total, we had more than 1,000 samples. And at age 6, the real diagnosis was done. So then each child was assigned either to healthy, to wheezing group, or asthmatic. So just to insist on this, we had our strategy. So we look at our data, we focus on the training set where we try to find the compounds that can distinguish between asthmatic, wheezing, and also healthy. Then we validate our selected compounds, and then we move to visualization. Okay, are there really groups? Okay, so some results. So we were able to select 17 volatile metabolites in exhale breath of those children. I will show you first results obtained for all. So here I did not really look at age, but I decided, okay, let's see if I take all my 1,000 samples, can I see some trends? And this, what you can see here, is basically a scatter plot, and each point here is one sample, one breathogram, and the axis, if you look at the axis, you can consider it as kind of cocktail of those 17 compounds. So I can say, using those axes, how the compounds change and what is their contribution to distinguish my groups. And if you look at the figure, okay, it's not perfect separation, but we see clear 3 groups. So we have healthy, wheezing, and asthmatic children. But I told you that we are interested in the preschool. So ideally, we would like to see if we can predict asthma at age 2. And this is what we also try to do. So we check those 17 volatile compounds in breath, if they can distinguish children at age 2, and this is what you see here. So you see pretty clear groups. So you have the wheezing and asthmatic children. And again, the axis that you can consider as those cocktails, as kind of combination of those 17 compounds. But we can also look at our results differently. So we can see at the so-called ROC curve, which is basically a relation between sensitivity and specificity. And the sensitivity here is, okay, how well I can say that the child has asthma, and specificity here, how well I can say that the child has wheezing. And what you see here, that we have around 75% sensitivity and specificity. So, okay, it's not ideal, but I always say if I get 2 good results, that I'm worried, because then it means something goes wrong. I don't believe in 100% separation. Then, or experimentally went wrong, or from the data perspective, something went wrong. And again, to emphasize this point, the results that I'm showing you here are for the validation sample. Okay, so one malfunction checked, lungs. So let's move a bit lower, which is bowel malfunction. And here we look at the Crohn's disease, which is inflammatory disease with relapsing episodes. So it means that the patient has like active stages of the disease and also remission stages. And depending on the stage, of course, the patient has more symptoms or less. and needs more medication. And at this moment, the gold standard to really diagnose and also to define the stage of the disease is colonoscopy, which of course is a pretty invasive and, well, not pleasant procedure to follow. So what did we do here? We collected here feces, blood, questionnaire, and exhaled air. So feces were collected to get so-called calprotectin, which is used as a marker of inflammation in bowel. Then we use blood for CRP, which is basically overall inflammation, and a questionnaire to ask for the symptoms of the patient. So what we did then, we used those three parameters to define if a patient was really in active stage and in remission. So we had more or less 135 individuals. And then we say, okay, can we use exhaled breath to discriminate? So fast reminder, we follow the same procedure: training, finding the compounds, validating, and then seeing how the compound changes or visualize some groupings. So we found 10 compounds, and if I show you how those compounds predict disease activity, you can see here again a ROC curve, so the relation between sensitivity and the specificity. So sensitivity here is how well I can say that the patient is in the active stage, and a specificity, how well a patient can say that the patient is in a remission. We see here around 80%, which is pretty okay. We can also see how the compound changes, so we can represent it as a heat map. And what you see here is in the rows you see the compound, so each row is a compound, and in the columns you see individuals. And red here, of course you can use different colors, but for me red means well, hot, so it's upregulated here in the active group, and green is downregulated in the active group. So you see here that mostly we have upregulated compounds in the active group. And often I get questioned, yeah, but you would expect like red and green. But of course we look here per sample. So of course you have here biological variation. So therefore the changes, for some samples, the changes are bigger than for the other. Okay, so here are the gut malfunction. So that's also check. But I will stay in the same area of our body. And I want to show you results on the diet, which was a pretty special diet, where we look at the infant formula that was work done together with Danone. And unfortunately, we didn't work with babies, but we had crazy males who were able to drink ½ liter of infant formula. For those of you who have children, you know that this milk is disgusting, right? And they did it for free, eh? So they were really motivated, healthy, non-smoking, young males to help us in our research. So that was pretty nice. We had here a crossover design. It was double-blinded. And we had here 6 time points. So we sample exhaled breath before they drink their milk, and then 5 time points after. We had 2 formulas milk. We call it active and control. So active, it was basically having, the difference was different phospholipid size and also the coating. So the active one was more resembling human milk, and the control one was, it was Nutrilon, so it was available commercially formula milk. So then we asked, okay, are there differences? So here you see the design. So as I mentioned, it's crossover. We had 5 days washout between the 2 experimental days, and we tried to see if there is difference between active and control at each time point. And again, we follow a similar procedure. So we try to find the compounds, validate, and then visualize the results. So what we found that the only significant changes that we were able to observe were at time 240. So before the changes between the 2 products, so 2 milk, were not significant. And this is what you see here. So it's again a scatter plot. So each point here is a sample, and you see diamonds are active group, and cycles are a control. Of course, there is no perfect separation, but that just here is a visualization. And the lines that you see here are the 8 compounds that were found to be the most significant. And I can see here that the compounds that you see on your right are the ones that are upregulated in the breath of individuals that consume the active product, and the one on the left, they are downregulated. Okay, so now I will move towards, so I move from humans and move to animals, and I would like to show you animal model that we use in sheep, and we use it a disease that is called chorioamnionitis, and I have to look on a screen to read it because I found it very complex, a difficult name, and it's basically infection of amniotic fluid, and for pregnant woman, it's not really dangerous because a woman who is affected with this infection has basically flu symptoms, so she can have fever, she can be tired. But for an unborn baby, it's very dangerous because it leads to premature birth and, of course, a lot of complication afterwards. And it's very difficult to diagnose. And the only way to do it is basically you have to take a sample of the amniotic fluid, which is very invasive and dangerous. So what did we do here? So we use sheep, and you would ask, well, why sheep? Apparently, the pregnancy is very similar if you compare female and a sheep. So therefore, we use that. And those poor sheep were infected with the Ureoplasma parvum to basically trigger this infection of the amniotic fluid. And what we did here, we had a special mask to sample them. So we had like, they were inhaling, and they were also inhaling into Tetler bag. We collected breath at several time points, so it was, of course, before, so baseline, and then 6 to 7, sometimes days after the infection. What is important to say here is that we had, well, 2 studies here. So first we had 4 animals. I know that it's very little, and I hate to work with such a small data size, but, well, from the ethical perspective, it was really, it was great that we could have 4 animals. So we managed to have 4 animals in January 2017 and 4 animals in 6 months later, so in July. So what we did here, we decided that the animals that were sampled in January were used as discovery set, and the one measured in 6 months later were used as an external validation set. So we again follow similar procedure, but here additionally we have this external validation. So this is what we used here. Okay, so we looked first at our discovery set, so the 4 set of animals sampled and well studied in January. We found out 19 volatiles. You see here visualization. So if you are careful, and I think it's pretty clear that I combine days. So I combine day 0 with day 1 and the 2 last day points, which is 5 and 6/7, to be honest. And why I did it? Basically, I did it to improve my power. And of course, before doing it, I check if there are differences, because if you have differences, then obviously you don't want to put it in one group. At day 0 and 1, I could not really see much differences in Excel breath, so therefore I said, like, okay, let's put it together. So you see it's just the visualization. Again, my axes are this cocktail of those 19 compounds, so that there is clear differences between infection and non-infected animals. But of course, I want to check if those compounds are real. And this is what you see here. So this is the ROC curve that I did using those 19 compounds, but taking the animals sampled in July. So it means the samples taken 6 months later. So it is here independent validation. And to be honest, when I saw this, I was pretty happy because, well, we have such a small sample size, and we could still validate it. We are now currently identifying compounds, so I don't know yet what the compounds are. Maybe they are all really nothing to do with the disease. Hopefully not. So, well, I hope that next time I can show you some name of the compounds. So because we were able to validate it, then I said like, okay, let's see if I combine all my data, how the groupings looks like, and this is what you see here. So you see here that there's again clear groupings between my infected animals, so it's a kind of brown, yellow cycle, and the blue, which is non-infected. Okay, to summarize, well, I try to give you a really broad overview of different studies that we do, so different diseases, different malfunction. Well, we all know that the axial breath is not just lungs, but it can go beyond that, and different diseases can be studied. Okay, we use different real-life cohorts, but I also showed you a study that we do in animal model, and I think that's from my field that just to be cautioned, the breath data are complex, and we also have to be careful how we analyze the data and always validate. And with that, I'm done for today. So thank you very much for your attention, and I will be happy to answer any questions.
So thank you, Aggie.
Thank you.
That was to the minute perfectly timed.
Yes, okay.
So we have 5 minutes for questions.
Wow.
I think Addie here has a microphone, so please, anyone? Yep.
Thank you. I was very interested in your paediatric study. Could you say a little bit about how you divided up those children into the 3 groups? What were your criteria for differentiating the wheeze from the asthma?
Yeah, so at age 6, they were diagnosed by a pediatrician. So they were following normal asthma diagnostic. So there was sputum taken. They did also, I think, spirometry and so on. So it was all like you would diagnose asthma. So this is what was done. Yeah.
How well confident are you on the instant results of the breath test? I mean, what other variables could be influencing the instant result? For instance, in Crohn's disease, I'm a gastroenterologist.
Yeah, of course.
In Crohn's disease, the patient may have had antibiotics the day before. He may have had a big meal in a restaurant. How does that influences the result?
So I did not show it to you, but obviously we checked the effect of any medication that the patient was taking. So we did not take the effect of the medication the entire breath, because then of course you will find it. But we tried to check if the compounds that we selected there were affected by the medication. And we did not see a significant influence. Of course, if you take the entire profile, you will find compounds that are related to the medication. So you also have to take it into account. We always check like drinking habits, smoking, supplements. We take into account diet, but we here we did not really take a very broad food questionnaires, but we only ask, okay, do you follow certain diets? So are you vegetarian, are you paleo, or carbohydrates, or vegan, or any other diet that you can think of nowadays, gluten-free and so on. So this we did check it here, and we always do that. And we know that exhale breath is affected by other factors.
You are confident the result in each individual is consistent. If you repeat it at a different point in time, the result will be similar.
We are now currently trying to validate this study in the new cohort. So, of course, if I repeat my analysis, then yes, I am confident. But I will be 100% confident if I can validate it in the independent study. So then I'm really confident. In any study in the literature, if I see if it's validated properly in the independent, then I can start trusting the results. Because those are complex techniques. You know, it's math, right? If you ask the algorithm, okay, find something, the algorithm will do it. So you have to be careful. So.
Thank you, Aggie, for that overview. What I'm wondering is, across the many studies that you and your team have done, what kind of similarities have you found between the types of biomarkers that you have observed? Is there any sort of common set of biomarkers that you seem to see across a range of diseases, or does this seem to be quite specific for disease?
Well, I have to say that if I look at IBD, we very often find some short-chain fatty acids that are changing, because we did also study on the colitis, and we see that there are short-chain fatty acids changing. We see also, for instance, isoprene, but I know that there is a lot of speculation about isoprene, if it's really inflammation or not. We see, if I compare, like for instance, in the liver, we see a lot of sulfur compounds, which we do not really find so much in the other studies. But in order to really find a specific marker, what we should do here is to take my IBD patients and compare it with liver and so on, you know, so do try to be very specific. Or for instance, if I speak about IBD, I take my IBD patients, my colitis and Crohn, and compare it, for instance, with irritable bowel syndrome, and take some other malfunctions occurring in gut. And then you can be really, really specific. So there is small overlap, like I said, with the short-chain fatty acid, but there are also some differences.
Time for one more. All right. Please say your name when you ask the question and where you're from.
I'm Murad from Overstone. Congratulations for a nice talk. I want to ask regarding the pediatric asthma test.
Mm-hmm.
So asthma is characterized by flow limitation when we have a forced exhalation, which I could just imagine that kids, when they are asked to blow into the bag, they would do it. How would you compensate for maybe the loss of VOC's flux from the blood to the alveoli in this blockage?
So what was done here, we did not really, we just took the complete breath. So the children were asked just, they had a special mask, so to help them, so they were not too, because if you blow to a Tetler bag, there is pretty big resistance. They had a mask, then there was also a carbon filter, and then they were just breathing to Tetler bags. So we did not really, I understand, to take into account, the difference in the flux. So,
excellent.
but we are validating now this, and then we are moving. So we have a second, we call it ADAM study. We have a second study where we are trying to do that. We even try to use Reciva, but for kids it's very difficult, 2 years old. So, yeah.
Excellent. All right, everyone, please give a round of applause.